So the permanent system is implanted with a general anaesthetic. So it's a little more invasive. We make a bigger incision over the back of the head at the junction between the head and the neck. We place the electrodes across the occipital nerves, and we tunnel the electrodes down the neck, typically to the pectoral region, where we implant one of these batteries that you see on the right of the screen. Permanent implantation does offer a significant benefit in the majority of patients that have had a positive trial. So the trial is a very good predictor of whether they're going to have a good outcome with a permanent system. There is a significant minor complication rate. These patients can be prone to infections, to leads migrating. It's not uncommon to have to take patients back once or twice or even more often to fix things up. And the neck and the head are such mobile parts of the body that when you're putting pretty flimsy electrodes in and you're stitching them to the fascia, or you're hoping they stay there, and you can't control exactly what someone does when they go home, and sometimes you can't control various anatomical factors as well. So the revision rate is significant, and a small percentage of these patients will have a benefit for a while and then they'll lose that benefit, and you may decide to take it out at that stage. Now, there have been a number of published trials in the literature to look at occipital nerve stimulation, quite a number of trials. Most of these studies have been very, very small. We haven't seen much randomised control data out there. You'd have to say the quality of evidence, the quality of most of these studies is not crash hot. But what they do suggest, and certainly what our clinical experience has suggested, is that at least 2/3 of these patients do get a benefit from their trial and they go onto a permanent system. 80% of those that go onto a permanent system do derive a significant benefit from that permanent system. And on average, the pain scores will reduce by 60 to 70% in those patients with a successful trial. So if it works, it usually works pretty well. My experience has been that it either works really well or it doesn't work at all. You don't get a lot of patients that sit on the fence. And fortunately, you can make that distinction at the time of the trial. When it comes to occipital nerve stimulation for migraine, there have been a number of studies done. Fortunately, these studies have been larger with a longer follow-up. And I've just put up this study here to show that in these 25 patients, they had a reduction in their migraine disability score of 90%, and their headache frequency reduced by 50%. So we are seeing a treatment that's certainly not a cure, and making sure that patients have a realistic expectation of their surgery is critical. But it can help, and it's obviously not going to replace their other treatments. They're still going to need to have their medications, their psychology reviews, all of those sorts of things if that's what they're having. In my experience, it rarely replaces their other forms of treatment, but it can be a big help for some patients. Cluster headaches is another condition that's generally seen by neurologists. We had an exciting couple of years where a few groups, particularly in Italy, published some deep brain stimulation data on treating cluster headaches, stimulating the hypothalamus. And they published very, very good results. We then had a period of time where those results looked a bit iffy. There was one equivocal trial that came out, and people started looking at occipital nerve stimulation for cluster headaches. And the results have been at least as good, if not better, than the originally reported DBS outcomes. And so what we've seen is that occipital nerve stimulation and sometimes supraorbital and supratrochlear nerve stimulation has really replaced DBS as that final treatment option for some of these patients with cluster headaches. And the data there, again, you're talking about very small studies, but the data is encouraging, and certainly encouraging enough for people to be looking at larger studies at the moment. So you can look at other types of facial pain as well. The first patient I did peripheral nerve stimulation on was a truck driver who'd smashed his forehead against the steering wheel of his truck and damaged the supraorbital and supratrochlear nerves, and he had very bad neuropathic facial pain. And after trying everything else, we put in some electrodes there, and he's now 5.5 years down the track. He's back at work. He's not on any medications, and he's probably been the best success I've had with any type of stimulation, probably with any type of surgery, really. But that's pretty rare to get something like that, an outcome like that. But certainly the neuropathic facial pain syndromes any nerve that can be damaged can also be stimulated. So it's something that you can do. And again, we're seeing more small series published. People are sticking electrodes basically everywhere at the moment. And whilst that can be good, that can also be a potential problem because there's a degree of self-control required amongst the implanting community, and we hope they act responsibly. Complex regional pain syndrome. I'll talk about spinal cord stimulation for the treatment of complex regional pain syndrome, but where you have pain that is correlating fairly well with the distribution of a particular nerve, you can stimulate that nerve and you can obtain a reasonable benefit in a lot of patients. This study demonstrated 63% good or fair results in the long term, and they found that the patients where they tried to do this procedure on that actually had pain and changes distributed much more widely than a single peripheral nerve did not do any good. And so that's why you would only think about peripheral nerve stimulation in the complex regional pain syndrome context if it was very confined to a single nerve. So I'd like to move on to pain of spinal origin because the evidence for spinal cord stimulation is certainly a lot more compelling. It's a higher class of evidence. We do have some class 1 data, and really this is something that even I'm surprised how often the neurosurgical community doesn't know about this. They either don't know about it or they don't believe it. Certainly the orthopedics community and particularly the general practitioners need to be more aware of spinal cord stimulation. So pain of spinal origin can arise from any structure in the spine. It's most commonly soft tissues, musculoligamentus. It's often discogenic, whether that's from the disc itself, if they've got an annular tear, or whether they've got irritation or compression of the nerve root, or irritation or inflammation of the nerve root as a result of some of those inflammatory mediators that will come out of a ruptured disc. Facet and sacroiliac joints often cause spinal pain and pain radiating into the arms or legs, and previous spinal surgery, as I mentioned before, can be a big contributor to some of this. And you've always got to have in the back of your mind the possibility of less common but more serious underlying causes such as infection, tumour and instability as being possible causes. So the three main types of spinal surgery that we do, the most common type in my practice would be decompression, either in the form of microdiscectomies or laminectomy type procedures. We often do stabilisation procedures in the form of fusions, and neuromodulation is really what I'd like to talk about today because the talk should be confined to something that's a little bit newer. Spinal cord stimulation is the first of the neuromodulation options when it comes to the spine, but over the past 5 or 6 years we've seen the emergence of this other technique called lumbar regional field stimulation, which is basically a fancy term for just putting electrodes in the back in the area where the pain is and seeing whether that improves things. Spinal cord stimulation involves implanting either percutaneous-type electrodes or a paddle-type electrode over the back of the spinal cord. It's an extradural operation. You put it over the top of the dura and it sits there and it's connected by extension leads or by the leads of the paddle themselves to a battery which sends the electrical impulse. And where you put it in the spine depends on where their pain is. The main indications for spinal cord stimulation are failed back surgery syndrome, where they might have significant ongoing leg pain that's not thought to be due to some sort of instability process. A complex regional pain syndrome, peripheral neuropathy can respond well in some cases, and I mentioned before ischemic heart disease and peripheral vascular disease, but I won't get into that today because we don't really get those referrals. The vascular surgeons and the cardiologists like to treat those by treating the primary issue, but there are some very sick old patients that can't have a coronary artery bypass graft or even a stent, and in those patients for angina, for example, they could be considered for spinal cord stimulation. There are so many different electrodes on the market at the moment, and the number of electrodes and devices that are being produced and distributed is rapidly expanding. That's just some of them. And that's what a paddle electrode looks like schematically when it's placed. I do these by doing a small laminotomy, so you remove a little bit of the lamina and you can place the electrode under direct vision, and I find that gives a reasonably good result. Doesn't cause them a lot of post-operative pain. These are some Percutaneous-type electrodes. That's the sort of thing that Richard Sullivan does, where he'd put those electrodes up the back of the spinal canal. And the advantages of spinal cord stimulation are that it is a pretty safe procedure. It's pretty uncommon to get a serious complication. You know, infection and bleeding can certainly be issues, but generally you don't see many complications or many serious complications with these options. You can do your on-table testing. It's not destructive. You're not doing a cordotomy. You're not cutting anything. It's reversible and adjustable. And whilst the cost initially, the cost of the stimulators is very expensive, upwards of $30,000, the cost is very high, it tends to pay for itself after a couple of years. The disadvantages of spinal cord stimulation are that it's not a cure for everything. You know, this is something that has very limited indications, and you need to pick the patients well. Some patients simply don't respond. The equipment might fail occasionally, might move. The short-term cost, as I mentioned, is high. They've got to have a lot of good follow-up. So you probably don't want to be doing this on someone who lives out in the sticks somewhere, because they're not going to be able to come and have their battery checked out as often as they might need to. And there is a steep learning curve. So I mentioned about the percutaneous-type leads. These can be placed under local anaesthetic via a TUI needle. And what happens there is that the electrodes are positioned, you do some on-table testing, and they're secured, and you can even test them off-table for a period of time, much like the occipital nerve stimulation patients. The paddle-type electrode, which is my preferred approach for the permanent implantations, tends to allow you to get current spread across a broader part of the spinal cord, and probably allows you to get better coverage in terms of back pain. I think both techniques are very good for leg pain, but I've found that using the paddles can be much better for back pain as well. So my preferred approach is to have the pain specialist do the trial, and for me to do the permanent system once we know that the trial is successful. It is slightly more invasive. I tend to do it under a general anaesthetic, but it's much more stable. You can actually stitch the electrode there, and I haven't had any of these move. And that's what the final system looks like. We've now got rechargeable batteries, so whereas before patients had to come back and have their batteries changed every now and then, you can get away with a battery for 9 or 10 years.